The crux lies in the definition itself. Febrile neutropenia. This is the most important emergency as far as oncology training is concerned or oncology work is concerned. So febrile and neutropenia means fever and neutropenia. So how do you define fever? A single temperature of more than 101 or a temperature of more than 100.4 for 1 hour. That is fever. So a person who has a temperature of 101 or 100.4 for a period of 1 hour is febrile, and neutropenia is a WANC, absolute neutrophil count, of less than 500, or a count which is going to fall to less than 500 in less than 48 hours. So to keep it simple, somebody who has fever and somebody who has a neutrophil count of less than 500. This is neutropenia. There is a definition of profound neutropenia, which we see in the leukemic patients and the transplant patients. They are those patients who have a neutrophil count of less than 100. So that's a profound neutropenia. Why do you need this definition? This is to identify the sickest of the sickest lot. So somebody who has an ANC of less than 100, we know they're going to be sick. So you're going to be more careful with them.
Should watch out for.
So from a nursing point of view, again, the most important thing is you have a cancer patient. The patient has recently received chemotherapy, especially liquid tumors like AML inductions, transplant patients, solid tumors receiving high intensive chemotherapies like docetaxel, MVAC regimen, adriamycin cyclophosphamide regimens, just to name a few. Those who have not received prophylactic growth factors, elderly, frail, those who have comorbidities, these are the patients whom you will watch out for. I have an elderly comorbid gentleman or a lady who has any tumor, who has cancer, who has received adria cyclophosphamide, no prophylactic growth factors, docetaxel, MVAC, leukemics on induction, who receive high dose Aracy, cytosine arabinoside, or transplant patients, they come with fever. The first diagnosis is going to be febrile neutropenia in the emergency room. So the first thing you're going to do is, again, airway, breathing, circulation, measuring the pulse, temperature, and respiratory rate. Clinically, you are going to classify these patients as low risk or high risk. So what is a low risk or high risk? Somebody is walking, talking, coming into the emergency, fit young guy, no comorbidities, solid tumor, has received growth factors, fever, but blood pressure is fine, urine output is fine, mental status is fine, respiratory rate is fine, no tachycardia, they would qualify as low risk. So you are not really worried about them. But somebody who comes in hypotension, hypoperfusion, seizures, altered mental state, coma, anuria, a leukemic patient, or all those high-risk patients which I mentioned, they are your high-risk patients. So you'll immediately secure a line, as we discussed earlier. You have a central line or a central potacath, or you will put an IV line immediately. Check for airway, breathing, and circulation. Watch for fluid overload, but you will start aggressively hydrating if they are in hypotension. Obviously, oxygenation. You will immediately start them on empirical antibiotics, pending cultures. This is the most important line we should emphasize to our nurses. You are going to send samples for your complete blood picture, which will look at your neutrophil count, your hemoglobin, your platelet count. You're going to look at renal function test, liver function test, ABGs, lactates. But before all, when you send all this, despite all, you're going to do your blood cultures from two lines, one from your peripheral and one from your central, aerobic and anaerobic. But despite all this, you will empirically institute antibiotics, IV antibiotics for your high-risk patients. Because if you do not give antibiotics within the first 60 minutes, and some people say within the first 30 minutes of FN, the mortality is going to be very high. So you're going to stabilize ABCs, put a line, send the labs, not wait for the labs. If you think it is high risk, you will immediately give IV antibiotics. What are the IV antibiotics? You can either give with the carbapenems like meropenem or imipenem or cefepime or piperacillin tazobactam or cefoperazone sulbactam. Any of these are okay. You will institute these, and then you would follow up. And then the follow-up basically on changing antibiotics or antifungals or adding antifungals would be based on how the patient would eventually respond, maybe 3 to 4 days later. If the patient is responding, his sensorium is better, he's clinically getting better, his neutrophil count is on an upward trend, cultures are negative, he's afebrile, you won't tinker anything. You would continue the same antibiotics till the WBC goes up to 500, ANC goes up to 500. But if the patient is getting sicker by the third or fourth day, you would start worrying. You will probably do a chest CT. You will look for pulmonary nodules. You will add antifungals. Or if the culture is different, you will add the antibiotics based on your culture report. Also, one important thing to add is many a times our central lines which we put could get infected. So we have to be very careful from a nursing point of view, handling our central line devices, constant flushing, constant brushing, minimizing multiple people using the central line. And if the central line gets infected with Pseudomonas or Candida or non-tuberculous bacteria or the gram-positive bacteria sometimes, then it would warrant removal of the central line. So we have to be very, very, very.
Anything else to add on that topic, or any other messages for nurses?
So the simple message to end would be FN is an emergency, and we can get most of our patients of febrile neutropenia out of this critical condition just because of timely management. Nurses form the most important core in this because they would come to the ER. So timely institution of antibiotics within the first 30 to 60 minutes, number one, sending 2 sets of cultures from the central and peripheral line, the antibiotics which I mentioned, fluid resuscitation, following up on your cultures is very, very, very important. Extremely important is hand hygiene. This is how much ever you overemphasize is going to be less. A very good hand hygiene is extremely important so that we don't contaminate our patients' lines, which is most important. Empirical gram-positive cover is not required. We would add gram-positive cover only if we have culture-positive bacteria. Each hospital has its own antibiotic policy. So based on your antibiotic policy, choose which antibiotic to be started empirically. And antifungals will be added if you have pulmonary nodules. You would add voriconazole. Or you would have candida, you would add amphotericin or caspofungin. One thing which you would add is at the beginning, which I forgot to discuss, is all the patients with febrile neutropenia, we're discussing about the high risk, would have a symptom directed imaging. That is, you would check with an X-ray or a CT for a pneumonia. You would check for an abdominal scan for abscess, for a source in the gut. You would do a urine routine or a urine culture if they have symptoms of urinary tract infection. And those patients who are in remission will require growth factor support. And once the patients are afebrile, once the cultures are negative and the ANC goes above 500, I think we have crossed.